Assalamu alaikum. Good morning, everyone. One of the issues and problems of being in a great conference like this, you sit for a long time, which has been equivalent almost to smoking. So one thing I'm going to do for your own health, I'm going to ask you all to stand up, please, and stretch yourself. Feel free to stretch. Don't just knock the one beside you. Thank you. So this was a trick to actually make you wake up. So thank you very much for your kind invitation. I would like to thank the scientific and organizing committee for inviting me. This is unheard of. This is the first time I have seen this, so congratulations for a great initiative. I hope this continues every year and with a lot of initiatives to improve the health of women and men both. So the title of this talk is basically reflecting a paper that was published in The Lancet last year that I have been part of. So before we delve into the full details of this paper, we'll go on the PURE study, or the Prospective Urban Rural Epidemiological Study, and define what is PURE. So PURE has been going on for over 1.5 decades and asks basically many questions to be addressed at the community level. You have the cardiovascular disease in the middle, and you have the usual causal factors that we know as causing cardiovascular diseases. And then it goes beyond that to ask questions regarding the community effect on our health, the walkability of the built environment, safety, places for walking, the infrastructure of the community that allows you to follow healthy exercise and healthy lifestyle. And then going down to the food policy, access to healthy choices, exposure to unhealthy choices, air pollution, clean air regulations, tobacco taxes, prices, regulating age of use, smoking, and what have you. And then social networks and social capital. So it goes beyond just the regular measurement of the risk factors only, and actually goes beyond that to the community as well, and follow people as a cohort study over the years. So PURE now is over 200,000 subjects from 1,000 communities in 26 countries from 5 continents. So this is from the community and following people. These are not people who might not necessarily have heart disease. They're actually people from the general population, and involves many countries that you can see on the map, countries from our region here, United Arab Emirates, Saudi Arabia, Palestine, and Iran, and in addition to many other countries in the world. These are countries that joined forces together over the years. So they didn't join immediately at point zero. They basically sequentially joined one after the other over the years. The other important point is that merging this with the Canadian longitudinal study, it will be almost 250,000 of population. Same country, same study design, same CRF that they are filling together. So this is very important in terms of standardization of the data that is being filled by all these countries together. It involves annual visits to document events, repeat clinic visits at 3, 6, 9, 12, and 15 years. It involves the usual vital signs measurements, the diet and physical activity questionnaires, and extensive diet that even goes to the full details of even local diets, the health systems, as I mentioned, and then being adjudicated for death, MI, stroke, heart failure, and cancers. And there are other follow-up data that will be added as well in terms of aging and frailty, lung disease, and other things. It involves mortality follow-up in all non-participating household members as well. So it's not only picking the subject, it goes into the the household members and at least measuring the mortality in those who did not participate from the family. So I'm going to show you some pictures over the years. This is becoming almost like a big family. This is the investigator meeting in Bangalore, India. This is Salim Yusuf here in the middle, who is originally from India, who migrated to Canada, and he's the one who established the Population Health Research Institute in McMaster, Hamilton, Canada. This is in Hamilton in 2013. This is one of the pure investigators meeting. This is in Italy in 2016. And this is just recently Istanbul. This is just focusing on the Middle East. Some of the people who got engaged from the Middle East, Dr. Yusuf Ali and other research assistants and investigators from Palestine and other countries. And this shows you that it basically took almost a village to really run this study for over these years. Pure almost exceeded 300 publications, 4 in the New England Journal of Medicine, 27 in the Lancet and sister journals, 8 in JAMA and sister journals, 9 in BMJ and the sister journals, and in addition to many others. So it had a great impact on the way we understand medicine today. For your own reference, if you would like, we publish our own results from Saudi Arabia. This is a paper, it's open access, you can download it for free. And we started with Pure in 2012 in Saudi Arabia, and now we are finishing the 9 years follow-up of 2,000 subjects, following them up to 9 years. So this is just an introduction to what Pure is about. So it's important to understand what this original study is about before we delve into the actual results. This is one of the papers that is the subject of my talk today, which is Metabolic, Behavioral, and Psychosocial Risk Factors Comparing Men and Women in 21 countries for the sake of this sub-study. The first author is Marjan, who used to be a research fellow with Salim Yusuf and McMaster, and now she's back in Oxford, in addition to the investigators from Pure, including many people from this region. So the background, as you heard since yesterday, many great talks, and today, that the existing studies, mostly from high-income countries, have reported hypertension, diabetes, and smoking are more strongly associated with cardiovascular disease in women than in men. This is the premise, and spoiler alert, well, this might change at the end of this talk. Such findings would imply that women would benefit to a greater extent in reducing cardiovascular disease risk from control of these risk factors than would men. Data mainly from the Global Burden Disease study, it's a well-known study at the IHME Institute for Health Metric Evaluation in Seattle, Washington, combines disparate data sources. For those of you who are familiar with GBD, with many publications in Lancet and Lancet sister journals, they basically go to WHO and your Ministry of Health and ask for data, and basically try to model and estimate the results. So it's not really one study where everybody is following the same study design. It's basically asking each country to provide data. And many of the data internationally are based on the Global Burden of Disease study, which is a good study, but on the other hand, they are really sometimes comparing apples to oranges. Hence, there is a paucity of data on the prevalence of risk factors and their associations with incidence of cardiovascular disease in women compared with men, especially from low-income and middle-income countries. So the methods of the study, it enrolled participants from the general population. So the data that you're going to see involve patients, subjects from the general populations. They might not be necessarily patients, cardiovascular patients, from 21 high-income, middle-income, and low-income countries, and followed them up for up to 10 years. This is an average of 10 years. And we recorded information on participants' metabolic, behavioral, and psychosocial risk factors. It includes age cutoff of 35 to 70 years of age at baseline without history of cardiovascular disease for the sake to answer the research question with at least one follow-up visit. And the primary outcome was a composite of major cardiovascular events, as you can see here. We reported the prevalence of each risk factor in women and men, their hazard ratios, and population attributable refractions or PAFs, and I'll define that later, associated with major cardiovascular disease. It's also important to know what constitutes pure. High-income countries form 11% of the population that you're going to see now, and low-income/middle-income countries form 90% of the pure cohort. These proportions closely reflect the global population distribution by economic levels. So look at this as a global study and really interpret this in the context of your own country that you live in. So to start with table 1, this is comparing women versus men, women on the left side and men on the right side, and women almost 90,000, over 90,000 subjects, and men over 64,000. These are the baseline characteristics, number of events, and incident rates during follow-up. And as you can see, the average age is around 50 on both, and with equal proportions living in either in high-income or middle-income or low-income countries. But what's obvious here that women have lower number of events compared to men: major cardiovascular disease, myocardial infarction, stroke, cardiovascular disease, death, and age standardized incidence rate per 1,000 person years is also lower in women versus men. So this is the first important part of the results. When you compare the mean level of risk factors at baseline by age category in women and men, you can see here these are divided by the young, middle and older age, so 35 to 44, 45 to 54, and 55 to 70 across the x-axis. And here is the showing the systolic blood pressure, mean glucose, waist to hip ratio, and non-HDL cholesterol, men in blue and women in red. And as you can see, it's not a surprise as you get older, the risk of high blood pressure, higher fasting blood glucose, and so on, and higher waist to hip ratio is higher. 2, men have higher risk than women when it comes to high systolic blood pressure and fasting blood glucose and waist to hip ratio. But when it comes to non-HDL cholesterol, at younger age, men still do have high risk, but they become similar at middle age, and then the story flips as you get older. The non-HDL cholesterol gets higher in women. So higher in men at younger age in non-HDL cholesterol, and becomes higher in women once they get older. Let's look at the other risk factors: current or former smoker, consuming alcohol, low physical activity. And you can see here the men again and again has been shown that men smoke much more than women. They consume alcohol more, kind of low physical activity, slightly higher in men, but really they are very close to each other. Put that in the context of low physical activity proportion in our region, I think it's much higher. It's almost 60%, not the 10 to 20%. And poor diet, the pure score, there is a pure diet score of less than 4, which means it's a poor diet, and they are almost equivalent. So again, men higher in terms of smoking, consuming alcohol, and women, when it comes to consuming poor diet, they are more likely to be women. And when it comes to low physical activity, they are very similar. In terms of low grip strength, it's one of these standardized measurements of muscle strength, an indication of frailty, which has been associated with al-wahan, has been associated with a high risk of heart disease and mortality. They're almost similar. Again, similar exposure to household air pollution, but in terms of symptoms of depression, higher in women, and higher proportion of low education level in women. When it comes to the details of the cholesterol, total cholesterol is higher in men at younger ages, and as we mentioned before, as you get older, women become higher cholesterol, and this is the same story when it comes to LDL cholesterol and triglyceride more consistent, being men at younger ages and women at older ages, and with women higher HDL cholesterol. Whether this is associated because of the menopause effect or whatnot, we can discuss that. The issue of menopause in women has been really a very controversial issue over the years. Are women more likely to be protected because of estrogen at younger ages? And when they lose that estrogen, this is the result that we can see, still debatable. And to finish, this is the total cholesterol slash HDL ratio, higher in men, ApoA higher in women, ApoB higher in men, and then higher in women at older ages, and ApoB to ApoA ratio higher in men. So this is the first part, the risk factors part in general. If anything, it's actually higher in men. And then comes the really more interesting part with this, does that translate into mortality and high risk when it comes to composite endpoint? So this graph, this is the line of unity, around 1. Anything crosses the line means insignificant. On the right side means basically higher risk. On the left side means lower risk. And basically, this is high hazard ratio after extensive adjustment for other confounders. And as you can see, men and women, both of them, have higher risk of composite endpoints with higher blood pressure, hypertension, abdominal obesity, and diabetes, and so on. So unlike previous studies, actually this shows being a woman with diabetes still have similar risk to men with diabetes. Being a woman with smoking, or as we will come to the next slide, and hypertension still have the same risk, not necessarily higher risk than men. If anything, men actually have higher risk with cardiovascular disease if they have higher non-HDL, with high non-HDL cholesterol compared to women with high non-HDL cholesterol. To put that in the context, the stronger association described in previous studies for self-reported diabetes and cardiovascular disease in women than in men might be driven by the differences in the rate of diagnosis and differences in health-seeking behavior. So if you look at the previous studies, as we mentioned, most of them are from high-income countries, A. B, it also depends how did you measure diabetes? Was it actually self-reported or did you measure blood sugar? And maybe women are more likely to have their diabetes detected than are men. And the GBD Global Burden of Disease study reported that the total disability-adjusted life years due to LDL cholesterol in 2019 were significantly higher in men than in women, again confirming our results. When you look at the association with smoking, low physical activity, and other risk factors, what stands out are that men, basically smokers, and those, if men get depression, they are more likely to get cardiovascular disease than women. But when it comes to poor diet, if women have poor diet, they are more likely to get cardiovascular disease. Again, to put that in the context of the issue, well, if women smoke, they're more likely to be problematic than men who smoke. It's not necessarily so. The heterogeneity in conclusions across studies might reflect the distinct smoking behaviors in women and men from different regions of the world rather than differential biological effects. So it's not the sex per se, it's actually the behavior. Men smoke more, and maybe their behavior of smoking is actually worse than women. We already mentioned that the cholesterol issue, and the men, when they're with high cholesterol, total cholesterol, or LDL cholesterol, more likely to get cardiovascular disease than women with high cholesterol. How about high income, middle income, low income countries? Similar patterns of associations between women and men for risk factors and major cardiovascular disease were observed in high income and upper middle income countries and in low income and lower middle income countries. How about PAF, population attributable fractions for 12 risk factors with major cardiovascular disease in women and men? To define PAF, it is the quantity, it quantifies the proportional reduction in disease prevalence that would be achieved if the risk factors is theoretically removed from that population. So if you imagine that you remove, for example, hypertension, you remove almost 23% of the risk of the disease prevalence if you remove that risk factor. So you can see here that 58% of these risk factors that you can see explain and contribute to the population attributable fraction in women and 65% in men. So more risk factors contribution to men than women, and mainly driven by smoking. You can see hypertension contributes equally to both groups, 23%, almost a quarter in each. It is the most common. While high non-HDL cholesterol in men, 8.6% versus 3.2% as a contribution to population attributable fraction, and current smoking 10.7% versus 1.3%. While again, poor diet contribute more to women than in men. So to put this together, the added value of this study is the following. One, this is the first comprehensive overview of the prevalence of metabolic, behavioral, and psychosocial risk factors, their hazard ratios, and population attributable fractions for cardiovascular disease in women and men aged 35 to 70 years. Our results extend previous studies by reporting on a geographically diverse population from 5 continents and who did not have history of cardiovascular disease and were followed up for a median of 10 years. Compared with men, women presented with a more favorable cardiovascular risk profile. The hazard ratios for metabolic risk factor were similar in women and men, except for non-HDL cholesterol, for which larger hazard ratios for cardiovascular disease were observed in men. Larger hazard ratios for symptoms of depression were observed also for men than women. By contrast, diet was more strongly associated with cardiovascular disease in women than in men, which has not been described previously and requires independent confirmation. And the total paths associated with behavioral and psychosocial risk factors were greater in men than in women due to larger contribution of smoking to the overall paths in men. What are the limitations? One, it's an observational study. So you get the inherent limitations that comes along with it, including unmeasured confounding variables and missing data. Risk factors measured at baseline. So this did not account for changes in risk factors over time. And there are too few events to examine the association between each risk factor separately in women and men within several geographical regions. So for example, if you ask me, how about the Middle East compared to other regions? In this study, you still need a larger sample size and even longer follow-up than 10 years, up to 15, 20 years of the overall study to answer that question. So in conclusion, our results emphasize the importance of a similar strategy for the prevention of cardiovascular disease in both sexes. However, the increased risk for cardiovascular disease in men might be substantially attenuated with better reductions in tobacco use and lipid concentrations. Well, does it apply to women versus men in our region? I don't know, not sure. What really we need in this part of the world is something like this. The Population Health Research Institute in Hamilton. It would be really great to have this in each country that runs such major studies to answer such important questions. This is a proposal that I'm working on, a Population Health Research Center. I submitted it to my college. We'll see how it goes from there. And then I will finish by my best advice for all men to live longer and have peace. Thank you.